Good afternoon, colleagues. It's Dr. Richard McCallum, editor of the Journal of Investigative Medicine. And as is our monthly habit, we conduct a podcast to the AFMR members, as well as other colleagues in the country. And we invite an expert to address a topic that we believe will be of great benefit to our membership. As a background, why did we choose this month's topic? Well, Karina Espina, my trusted editorial assistant and co-moderator of the podcast, informs me about each month's sort of highlights, colon cancer month, diabetes month. This month is actually on thyroid disease. And so it was a bit of a no-brainer for me because I have a great expert here at Texas Tech University Health Sciences Center in El Paso, Dr. Tamis Bright, and she was very glad to join me on this podcast today. And we're going to discuss the thyroid. Before we get to that, let me just briefly introduce Tamis to you. She comes from that world of Hanover, the Big Green, Dartmouth College, where she studied after attending Exeter Academy, did medical school at Loyola in Chicago, going on to an internship in San Antonio, Texas, followed by completion of residency, and then completion of a fellowship in endocrinology at the University of Colorado. I guess that was before it moved to the new location there on the Air Force Base in Denver. Tamis then came, fortunately for us, directly to Texas Tech and assumed the role of Division Director of Endocrinology and Metabolism. Soon after that, also became the Associate Program Director for our internal medicine residency, where she's done a stellar job at that for over 20 years. She retains and remains the division head of endocrinology, and that's how I met her when I came here myself in 2009. Tamis was our right-hand person, if you like, in the world of diabetes and gastroparesis and some of the GI motility areas of research that I work on. And I got to know her very well for other expertise in all areas of endocrinology. Tamis continues to be active in both abstracts and in publications. She's an associate professor of medicine here in the department and continues to be a major teacher for our medical students and residents. So it's a pleasure for me, Tamis, to welcome you and thank you for joining us on this podcast.
I'm delighted to be here, and I'm really happy to be part of Thyroid Month, and hopefully we can impart some information for the listeners and spread the word about things about the thyroid for you.
Thank you very much. It's although we don't need to know this, her husband actually is very glad to take out some thyroids now and again. As referred to. So one of the reasons one might get involved with resections or surgeries could be the mysteries of the thyroid nodule. Tamis, why don't I throw that little challenge your way first of all, and you can perhaps give us your view on how an internist and others would view a thyroid nodule and how we can evaluate it.
I think that's a good topic for everyone because we do so many x-rays that include the thyroid. So it isn't just the internists and the family practice docs that see these, it's everybody, since every chest CT that we do, or if you're doing a carotid Doppler, the thyroid is in the image, and then, whatever it was that you were looking for. Oh, by the way, the radiologist is reading that you have this 2-centimeter nodule or a 5-millimeter nodule or, endless nodules that show up. And then you're stuck with, well, what am I supposed to do with that? And this is one of the frequent questions that we get and the frequent consults that we get because so many people do have nodules. And if you're looking at an older population, you probably have at least 10% of them are going to show up with incidentalomas, whether you could palpate it or not. Many of them are quite small. And then you need to know, well, what am I going to do with this thing? So the first approach pretty much with all thyroid disease is we live off our labs. So what is the TSH? And we want that TSH first to know is the patient has some other functional abnormality as well as a structural one with the nodules. So we check that TSH and see, is that patient potentially hyperthyroid, because that totally changes the management that we're going to do. Because when you have a nodule, your concern obviously is do you have thyroid cancer? And thyroid cancers are never functional in that they make thyroid hormones. So if you have someone that's hyperthyroid, now it's still possible it could be a thyroid cancer, but you need to know where is that hyperthyroid coming from. So in that case, you're going to have to do a thyroid scan and see, is that what we call a hot nodule or a functional nodule? And at that point, it's not cancer. So you still have to deal with that hot nodule and treat the hypothyroidism, whether you're going to use radioactive iodine or you could use a thyroid blocking medication like methimazole. But at least it's not cancer. And one of the mistakes that we see is that people try to biopsy these hot nodules, and you can biopsy it, but you already knew that it wasn't thyroid cancer. So there's no indication whatsoever with that hot nodule to do a biopsy. And indeed what happens, and one of our big concerns is when people do these biopsies, you put the pathologist in a very difficult situation because a hot nodule by definition is active. So if you're going to biopsy an active tissue, it's going to have active nucleoli. It's going to look like an active tissue. It frequently will have mitotic figures. So when your pathologist is looking at that, he's going to say, okay, I have this active tissue. I have these mitotic figures. He's going to have to read it based off his criteria that potentially is a suspicious lesion for cancer. And we know from epidemiology that it wasn't possibly a cancer to start with. So now we have a path report that says it's suspicious. The patient has that, and I go, we'll take it out. So now we end up with patients that potentially end up with an inappropriate surgery because you ended up doing a nodule that you really didn't need that biopsy on in the first place. So I think the most important thing to start with nodules is don't biopsy anything that comes out on a thyroid scan that's a hot nodule. It needs treatment for the hyperthyroidism, but it does not need a biopsy of that nodule. All the rest of them, though, potentially may need a biopsy. So if you have a patient that has a normal TSH or even a hypothyroid patient, now you need to potentially biopsy that nodule. And we do them under ultrasounds now. I mean, for many, many years, we obviously just grabbed a needle and stuck it in there. But now that we have fantastic bedside ultrasound machines, you can look at that nodule. You can really get a good assessment of it and decide, is this something that I need to biopsy? In most cases, if it's over a centimeter, we would consider biopsying it. If it's cystic, and many people do have cysts in their thyroid, if it's a pure, just, round bag full of water, that is a benign lesion and does not need a biopsy. But if it is any type of a mixed cystic or solid, then we would biopsy it if it's over a centimeter. And what we see frequently is because of all the x-rays, we have these people that have a 2 millimeter or 3 millimeter nodule. Those are incredibly common. Even if it's a thyroid cancer and it's 2 or 3 millimeters, they've been shown to be very benign behavior of them. There's no reason to be biopsying these things that are just a few millimeters. So it's important to wait until the thing is a reasonable size in order to start biopsying things. Do we occasionally biopsy things smaller if we know people have had familial papillary thyroid cancer or something like that might push us, but it's very rare that you would do a biopsy of something that's under a centimeter. And depending upon what they look like under the ultrasound, some of them are even more likely to be benign and will wait until they're about 1.5 centimeters. So you need a pretty big nodule before we get concerned about it. So a lot of it's reassuring the patient that this is fine. And in most patients, unless there's some suspicious looking things about those nodules, even the bigger ones, 90% of them are benign. So we do a lot of biopsies to find those few thyroid cancers because we can cure that thyroid cancer just by taking out the thyroid in most cases. So we look a lot just to find those few that need to have something done about them, and reassure the patients a lot about the ones that are potentially just benign lesions. So anyway, that's kind of the long-winded answer as to what to do with that thyroid nodule. But it is probably one of the most common things that we see that people need to know what to do with, because, a lot of thyroid disease, the primary care docs can take care of, and this one always stymies them as to what are they going to do with those nodules. So hopefully that answers it for people.
Well, as an internist as well as a gastroenterologist, I always feel the thyroid. Sometimes patients say, geez, doctor, my family history is very positive for thyroid cancer. Or I may stumble into hypothyroidism, and I wonder, gee, should I ever get just an ultrasound on this patient's thyroid? I can't feel any nodules, but we've got the family history, or maybe we've just got a new onset of hypothyroidism. Should we do more sort of ultrasound screening in certain settings? I can't guarantee I'm ever going to feel a nodule sometimes.
But the current guidelines actually are to do an ultrasound only if you do palpate that nodule. So yes, you should certainly feel that gland. Thyroid cancer is actually, I think we're 12th at the moment for the most common cancers. So it's pretty high up there. And there's somewhere around, I think around 50,000 new thyroid cancers a year. Now, the prevalence is super high because, thyroid cancer is a pretty indolent cancer as things go. So people live a very long time. So there's a lot of people living in the U.S. with thyroid cancer. But to do an ultrasound, just to do one, we don't recommend that. So if you have somebody that has just a diffuse goiter, if it's small and you can tell that it feels just like a diffuse goiter, you don't necessarily have to be ultrasounding those either. Patients who have hypothyroidism, it's not indicated in someone that is just purely hypothyroid either. If you have something, though, that feels like a nodule, then yes, that's when it's indicated. Many of those actually aren't nodules. So if you have a hypothyroid patient, the gland, when you look at it, is very lumpy and bumpy. And when you feel that from the outside, obviously, it feels all the world like a nodule. But then when you look at an ultrasound, it's this what's called a bossellation. So the whole surface of it has these areas of hypertrophy because of the Hashimoto's that's going on. And you can frequently tell that under the ultrasound. Sometimes we end up biopsying them because some look more like nodules, but most of the time you can tell it's just the Hashimoto's. But definitely, I would encourage everyone to be palpating the thyroid because, like I said, depending on how old the patient are, you got one out of 10 people may have a nodule in there. And then the risk of thyroid cancer is certainly there. And if we're not palpating that thyroid, then, no one's ever going to find these things. And the key to all thyroid cancer is find them when they're little so that you can potentially just cure it with a simple thyroidectomy.
How about the family history? Does that lower your threshold?
It does. So certainly if someone has hypothyroidism, you should be checking that thyroid level frequently. If you've got family history, we recommend that you do it every year. If you have other autoimmune diseases, even if you don't have that family history, but if you have autoimmune diseases, or autoimmune diseases are very common in the family. So a lot of people have vitiligo, they have lupus, they have rheumatoid arthritis, anything like that. They should have a TSH done every year, or obviously if they have symptoms. As for when you might do another ultrasound on them, again, it really would be for someone that had nodules in there.
Okay.
Because what's going to happen is if you can't palpate the nodule and you do ultrasounds, what you're going to find are these, 2, 3, 4 millimeter nodules. And now the patient's going to have this, fear that, oh no, I have this nodule. What if it's cancer? And you're going to have to spend the time reassuring them that it's okay. You can have this little nodule, but they end up getting more worried about it.
Sure.
And now you have the well-worried patient, and
Right.
add that to their stress and everything else, when really that does not change their morbidity or their mortality.